This workshop under the topic of Omics for All, how can genomics transform the advancement of disease diagnosis, contain many segments from experts in various fields of study. Ladies and gentlemen, for this first opportunity, I would like to invite Dr. Saowalak Dansakul, CEO of Bangkok Genomic Innovations, BGI Genomic Local Company, to give us a welcome speech. ในลำดับแรกขอเรียนเชิญดร.สาวรัตน์ ด่านสกุลประธานเจ้าหน้าที่ฝ่ายบริหารของบริษัท Bangkok Genomic Innovation ซึ่งเป็นบริษัทในเครือของ BGI Genomic กล่าวเปิดงานนะคะเรียนเชิญค่ะ
ค่ะสวัสดีทุกท่านนะคะวันนี้บรรยากาศอบอุ่นนะคะเราจริงๆน่าจะกับท่านอาจารย์ทุกท่านแล้วก็ได้รู้จักกันมาก่อนหน้านี้แล้วบรรยากาศของวันนี้ค่อนข้างที่จะเป็นห้องเล็กๆที่เราได้มีการแลกเปลี่ยนนะคะโอเคค่ะก็กราบสวัสดีอีกครั้งหนึ่งนะคะท่านศาสตราจารย์นายแพทย์วรศักดิ์โชติเลอศักดิ์ค่ะดร.ศิษเดชทองสีมานะคะแล้วก็Associate Professor Saharuddin bin Mohamad นะคะแล้วก็ผู้มีเกียรติทุกท่านนะคะในวันนี้ค่ะในหัวข้อที่ทางผู้จัดดิฉันในนามของผู้จัดของ BGI แล้วก็ BGI Bangkok Genomic Innovation ซึ่งเราเรียกสั้นๆว่า BKKGI นะคะขอยินดีต้อนรับทุกท่านนะคะเข้าสู่งานสัมมนาของเราซึ่งในส่วนของ Omics เนี่ยจะเห็นว่า Omics กับ Genomics เนี่ยค่ะณปัจจุบันมีการพัฒนาอย่างรวดเร็วนะคะและปัจจุบันนี้เนี่ยก็ถูกนำมาใช้ในหลายๆด้านในส่วนของทั้งเรื่องของการ Screening ในส่วนของการคัดกรองการ Diagnostic ถึงแม้กระทั่งในการรักษานะคะแล้วก็วันนี้เนี่ยเราได้รับเกียรติจากท่านอาจารย์หลายๆท่านเลยค่ะที่มาให้ความรู้กับเราในเรื่องของ Rare Disease อาจารย์วรศักดิ์จะมาบอกเราว่าโรคที่เราไม่รู้ว่ามันเกิดมาเป็นเพราะอะไรนะคะกลไกการเกิดเป็นยังไงมาตอบคำถามต่างๆเหล่านี้เราจะได้รับความรู้กันค่ะและอีกอย่างหนึ่งนะคะในงานนี้ก็คือจะในเรื่องของ Genomics Thailand ค่ะ Genomics Thailand เนี่ยมันเป็นความภาคภูมิใจของคนไทยที่เราจะมีดัตต้าเบสนะคะณปัจจุบันเนี่ยทาง BGI เองก็เป็นส่วนหนึ่งนะคะที่ได้ร่วมในโครงการนี้โดยที่ทางในส่วนของห้อง Lab WGS ที่ม.บูรพาในเขต EC เนี่ยได้ถูกใช้ตัวแพลตฟอร์มของทาง BGI ก็คือ T7 ของเรานะคะได้ใช้ในโครงการนี้ด้วยค่ะนอกจากนั้นนะคะก็ท่านอาจารย์บุญศรีนะคะก็จะสวัสดีค่ะอาจารย์จะมาให้ความรู้ของพวกเราในเรื่องของการ Screening Newborn นะคะและอาจารย์อีกท่านหนึ่งตั้งใจกำลังเดินทางมานะคะจะพูดเกี่ยวกับเรื่องของ Cancer Screening และท่านอาจารย์จากมาเลเซียค่ะก็จะมาแชร์ Experience ในเรื่องของ Rare Disease ค่ะในการนี้ก็ขอให้ทุกท่านนะคะใน2ชั่วโมงนี้ให้ได้ความรู้กันเต็มที่ค่ะขอบคุณมากค่ะ
ค่ะต้องขอบคุณดร.สาวรักษ์ด้วยนะคะสำหรับ Welcome Speech ที่แสนอบอุ่นดีค่ะและถึงเวลาแล้วนะคะสำหรับการเริ่มต้นบรรยายในหัวข้อแรก Genome sequencing provide life-changing diagnosis for rare and undiagnosed disease โดยได้รับเกียรติจากศาสตราจารย์นายแพทย์วรศักดิ์ โชติเลอศักดิ์ผู้อำนวยการศูนย์เชี่ยวชาญเฉพาะทางด้านเวชภัณฑุศาสตร์คณะแพทยศาสตร์จุฬาลงกรณ์มหาวิทยาลัยมาบรรยายในวันนี้นะคะขออนุญาตเรียนเชิญอาจารย์ค่ะ
ครับสวัสดีครับผมขออนุญาตถอดมาสก์กันนะครับเราอยู่ห่างกันเกิน2 เมตรก่อนอื่นต้องกราบสวัสดีนะครับทั้งท่านอาจารย์ทุกท่านครับProfessor Mohamad อาจารย์ศิษเดชอาจารย์บุญศรีท่านอาจารย์สุทัศน์ท่านอาจารย์ทุกท่านท่านผู้มีเกียรติทุกท่านนะครับแล้วก็ขอบคุณทาง BGI นะครับที่ให้โอกาสผมมาแลกเปลี่ยนผมจะขออนุญาตเล่าตรงปลายทางเลยนะครับว่าเทคโนโลยีทาง Genomics เนี่ยมันมีประโยชน์อย่างไรกับโรคพันธุกรรมนะครับโอเคครับผมจะมาแลกเปลี่ยนให้ฟังนะครับว่าการหาลำดับสารพันธุกรรมเนี่ยมันสามารถที่จะให้การวินิจฉัยที่เปลี่ยนแปลงชีวิตได้ยังไงนะครับกับโดยเฉพาะยิ่งเรื่องของผู้ป่วยที่เป็นโรคพันธุกรรมนะครับเริ่มต้นเนี่ยผมขออนุญาตย้อนเวลาพวกเราไป22 ปีเจอน้องคนนี้ก่อนนะครับเป็นช่วงเวลาที่ผมเริ่มที่จะดูคนไข้เป็นคนแรกๆนะครับแล้วก็วันหนึ่งก็เจอน้องคนนี้มาตอนนอกเวลาแล้วนะครับผมเป็นเรียกว่าวอร์ดสตาฟคือเป็นหมอที่รับผิดชอบดูแลตอนนอกเวลานั้นนะครับไม่คนปรึกษาใครไม่ค่อยได้หรอกตอนนั้นนะครับมันนอกเวลา น้องก็อายุ5 เดือนมาด้วยเรื่องที่เด็กก็มีอาการได้ประมาณเท่านี้นะครับก็เช่นมีไข้อาเจียนซึมลงนะครับมาหลายวันแล้วตอนนี้อาการหนักมากอ๋อโอเคโอเคโอเค thank you okay I was told to speak in Thai but I will switch in English okay so I share with you about how DNA sequencing could give a diagnosis that life-changing to patients with rare and undiagnosed diseases. So this is a patient. I bring you back 22 years to this patient. She is a 5-year-old girl with these symptoms, but so severe that if we couldn't give her a diagnosis, she probably gonna die in a few hours. So it depends on the medical team whether we could give a provisional diagnosis and give her a specific treatment. And we are so lucky. We mean this patient and our medical team because her disease just matched the specialty that I was trained for many years. Because of some clues, I could give her a provisional diagnosis of an inborn errors of metabolism, holocarboxylase synthase deficiency, and gave her a specific treatment. And you can see that within 2 weeks, she got much better and finally confirmed that she has this disease. 20 years passed. Now she graduated and has a degree from Faculty of Economics. Whoa! Sorry. ขอโทษครับน่าจะเสี่ยงไปนะเดี๋ยวมันจะตกอีกครับเอาไว้ที่พื้นเลยแล้วกันครับ Okay, just a little technical. Okay. Now, she's just one of several rare diseases. Rare disease is a group of disease. Individually, it's very rare. This is one of the definition. But collectively, because of there are so many diseases, established diseases, right now more than 7,000. But I'm sure that it has to be more than 10,000 diseases. Many diseases are waiting for us to establish. And so with this prevalence, 5 to 8% of the population, so the 70 million population of Thailand, there must be at least 5 million people in Thailand affected with one of these rare diseases. And more importantly, most of these diseases has genetic component. Unfortunately, previously we didn't have this tool. We did not have the right tool. So if the patient survived, we would have to take 7 years on average to give them a diagnosis. So for that patient, if she was affected with, let's say, immunodeficiency or neurological disorders, which did not match my specialty, she would have died already. But because we are so lucky that the specialty of the doctor matched with her disease, so she survived. And that's, I would call pre-NGS era, pre-next generation sequencing era, before the DNA sequencing technology has been advanced to date. We are so lucky. Right now, we have the right tool. You can see that these are the same thing, just this has been changed. We now have this right tool. So instead of taking years or even decades or never, now we can take just day to the diagnosis. We are entering NGS era. We have been in NGS era for a few years. This has been achieved because of the advanced DNA sequencing technology. In 1990s, when I was in training of molecular genetics, in one run, we can, probably have just hundreds or 1,000 base pair in one experimental run. 10 years later, it's increased its capacity 1,000 times to 1 million base pair in one run. And A decade later, 10 years, 10 years, the capacity increased another 10,000 times. So in 2 decades, the capacity increased at least 1 million times. It's not just faster, but it's also cheaper, 1 million times faster, 1 million times cheaper. So can you imagine? It moved from research lab to medicine, and not just tertiary medicine. It moved to public health. Now it has an impact for everyone. This center belongs to university, which has a mission to do research for scientific discoveries and teaching these scientists. We are also belongs to a hospital, King Chulalongkorn Memorial Hospital, which has a mission for service, medical service, and teaching medical personnel. And these are personnel in our team. We have from clinical geneticists, genetic counselor scientists, to do precision medicine. And these are the sequencers that we have. So we have short read, link read, long read, outer long read. So different questions, different issues need different tools. I share with you what we use this technology to change lives of our Thai patients. For example, for patients who yesterday were fine, but today somehow they are very sick, very ill, requiring ICU admission. These are acutely and severely ill patients. They did not have a history of drowning or being hit by a truck or having a toxic substance or anything. So what do you think? What happened to them? Why yesterday they were fine, but today they got so sick? No one knows. Conventionally, we have to test one by one. Test whether his or her blood has anything abnormal, their urine, the X-ray, imaging, MRI, or whatever. And it takes weeks if we are lucky enough to get a diagnosis. So our question is, it's possible that these patients has genetic disease. It's internal because they did not have any history of external problem. So it's very possible that they have internal problem that's genetic. So our question is, if we do sequence all the exons of our genes of these individuals, of these patients, could we get a diagnosis in time and change the management and change the outcome? So we get our first cohort, and we found that with using this exome sequencing as the first tier, we can get a diagnosis 46%, almost half. And that's changed the management and changed the outcome of many patients. I give you one example, this girl. She was so sick and almost died. We used this exome and found that she was affected with this, which is so rare, something so long. Fructose 1,6-biphosphate deficiency. I haven't heard. Oh, 5 minutes. Okay. If we get the diagnosis, the treatment is so simple. We just don't give her sugar or sucrose. We just give her glucose. That's it. So inexpensive. It's just the diagnosis, whether we can get the right diagnosis or not. If we can get it, it's simple to treat her. Because of the time limitation, I have to skip many things. This family has tremor. They have a very, they couldn't work because of this. We told them to follow these dots, and this is what they can do. They cannot sign, they cannot get the money out of the bank because they couldn't sign the same signature on their check. And they also have epilepsy. And we get the diagnosis, which lead to a specific treatment. And this is the result. You can see that how better they are from this to over there. And now they can draw, and now they can find a job. This is also a big cohort. Patients with pharmacoresistant epilepsy, 103 patients. Using this sequencing technique, we can diagnose them 60-something%. And that's changed their life because epilepsy is just one of the symptoms, but can be caused by hundreds of genes. And each gene has specific treatment. So if we can get to the root cause, we can give these patients a specific treatment and they get much better because of this technology. It's not just who see this. WHO, who is responsible for health of the world, of the global population, not just people of the high income countries. They have this committee, Science Council. This council has a mission to identify a technology that has an impact on global health. And the first technology that they indicate is genomic technologies. Also at our country level, he's still our prime minister. Well, thanks to his cabinet who approved this amount of money for Genomics Thailand. And you will hear about this initiative much more later. We form this network. We convince the policymakers that we shouldn't just make a database. Database doesn't mean anything, but we have to use this to apply it to change someone's life. And one of the areas that this technology has the most impact to is patients with rare diseases. And we got that. So 10,000 people with rare diseases is in this project. And this is a network. And the network really helped some of the patients. Well, unfortunately, I don't have enough time. And we are going to move to phase 2, from database and patients to healthy individuals. And you will hear more about how this technology could have an impact on healthy individuals, not just patients, and just have a database. Last slide. Individually rare, but collectively common. That's rare diseases. And this NGS technology revolutionized the diagnosis. So doctors can give specific treatment. And the next step, we are going to move from patients to healthy individual. Thank you.
So next, we will be in the topic of Genomics Thailand project from Dr. Sissades Tongsima, the director of National Thailand Biobank. Please give him an applause.
Okay. All right, here's my face, and you can also see me here. What Ajahn Vorasuk said is part of the big picture. When we talk about having diseases, not just only hidden by the truck or having toxic substances or getting COVID. Our life depending on the balance of the good genes and also the environment. So if you see at this picture, it sums up everything about the diseases. So the spectrum on the left-hand side is going to be genetic component. So basically, if you have the genetic component, it's going to be rare disease, meaning that if you have a defect, you get sick. And usually that sickness will come earlier at the very early onset, while some of the diseases happen while you are at this age. And that mainly because you have some defect, but that defect will not be representing the diseases yet until you expose yourself to the environment factor. Like for example, in COVID, some people who get COVID, they may have a severe case, and that could have come from partly the genetic and partly the environmental factor, which is infectious disease. Okay. So that would actually be what I want to say. Now, the problem of the study, not just only technology, whether it's ready for us to use, but also whether we have enough knowledge to be able to do diagnosis. In Dr. Vorasuk's case, basically if he identifies some of the mutation, and we all have like 100,000 of the mutations within us. How do we know if that particular mutation is actually an etiologic mutation, not just only pathogenic? Like the kids that he mentioned, if we have pathogenic mutation, we don't know if that mutation will actually cause the disease or the symptom that she needs that type of the treatment. So you may already notice that a lot of the countries start doing the population genomic project just to be able to collect enough variation into the database so that they will be able to at least use this database to help decide if that particular pathogenic mutation would likely be the cause of the disease. Unfortunately, most of the data out there, they are quite Caucasian-centric, meaning that they focusing more on the Caucasian. They are lacking of the African people, they're lacking of the Asian people. Maybe they have East Asian like Chinese and Japanese, but how about Southeast Asian? How about Thai? You know, we represent a melting pot of many other countries. You know, we have Malaysia, we have Indonesia, we have Vietnamese, we have Cambodia. And those are the things that underrepresent. So we need to have something to make sure that the collection of the mutation will be valuable tools for diagnosis. So the closest study that are out there and claim to actually represent the Southeast Asian would be the project done by the Genome Asia 100K. And if you go to that website and you look for Thai, there will be two, and that two actually living in Singapore. And I bet the two are Chinese-derived type of the volunteer, right? So just like Ajahn Vorasuk said, we have a genomic medicine, right? And we have a project that aims to construct a national reference variation database of the 50,000 Thai individuals. And we are focusing on many groups of diseases. So we have the first group is rare and undiagnosed disease. The second group is cancer. The third group is non-communicable disease. The fourth group is pharmacogenomics. And the last group is infectious. So you may already notice that they all rely on having a genetic data to be used in diagnosis and in treatment selection and also do a prognosis. But the way they use the data quite different. Okay, so the snapshot that I can show to you is that the project is $150 million US dollars. In Thai is about 4.47 billion Thai baht. Okay, so we're doing the 50K population genomics. We're using the DNB-seq T7 that will produce approximately about 6 terabytes per run, and one run require about 30 hours to do that. Okay, and it is the location of that one is in Marlborough Park, the 8th floor of the pharmacological science building. Yeah. So the cost, they don't want me to say that, but it's quite cheap because they basically want to actually help the country, and of course they try to drop their shirt and pants just to have this deal with us. So we break down the station into 5 stations. So the one that Ajahn Vorasuk mentioned is the T-Run, which is the Thailand Rare and Undiagnosed Disease Network. They will be the front line collecting the blood sample, recruiting the patients to be in this project. And then they will send the blood to Department of Medical Science in the Ministry of Public Health. There they will have huge facilities to extract the DNA. So all DNA will actually pass the standard and will be the same standard. We send the DNA to Thiomics, which is located in Marlborough Park, to do the sequencing. So once they do the sequencing, they will send the data to us here in number 4. Us mean myself and my team, to do the post-processing, and we also do the quality control of the data that they have sent to us. We prepare the data so that the doctors like Ajahn Vorasuk and his team would be able to select which mutation would be the etiologic mutation and then give a proper diagnosis and proper treatment to the patient. So just to give you some rough idea on how tough it is for me and my team to actually deal with this problem. The location of the sequencing center is about 134 kilometers away from where I put my HPC or high performance computer. And that usually require about half an hour to transfer one data, which is a size of 120 to 160 gig. So your iPhone 128, that data has to be transferred to where I am, where I was, my office. So that we need to improve the speed. We managed to actually send the 48 sample, which is one batch. Usually they would provide us with 60 individual in 30 hours, but due to the quality requirement, they have to actually reduce the number of sample down to just only 48 people for this type of the project. So our role is to design the HPC suitable for this project, because a normal HPC usually would take about 30 hours to do the post-processing of one individual. And that is too long, because if you multiply 30 hours to 50,000, 5 years, we're not going to finish it. So we managed to actually reduce the time of the processing down to just only lower than 2 hours. Some actually can make it 1 hour. So that would be what we do for the designing. We also need to make sure that the data that has been kept with us will actually be taken good care of, and by law, PDPA or GDPR, we need to actually make sure that no one will break in and then take the data away from us, right? We also developed the policy on the data sharing policy, and also the IP policy, IP sharing policy. Okay, so this is snapshot. You see, we start off in May or April and May. At a time, the data been sent to us about 500-ish number of the individuals. But at this point, we are at the September, October. We received so far 4,335 samples to be. Okay, they say that I have few minutes left. So, but I'm almost done. So basically, we process it. We use a standard that I call it de facto. De facto means what? Everyone uses it, and is internationally accepted. GA4GH is the organization that try to actually promote the use of the standardized method. We call it best practices in variant calling, and we use that, we adopt that. We are about to have the external quality assurance, just to see whatever we do here is up to the standard. Okay, so we also develop the software, the data management software. Everything is written from scratch. We have choices at the beginning, a choice of purchasing software from the company, or a choice of developing everything from scratch. And I chose the tougher one, which is developing everything from scratch. All these software are currently being used by clinicians to manage the data. And the last slide that I want to share with you is that we see ourselves as the computational genomic enabling platform. So what we do here is not just only for the project sequencing of the 50,000 individuals, but if you look at it, there are other demands from different companies who would make use of the sequencing technology. Some of them may want to do wellness, just like what Dr. Vorasuk said, the healthy people. Wouldn't that be nice if we would be able to tell, if you are running a risk of having certain disease, so that you can take good care of yourself? So we'll enter an era called preventive medicine. It's nice, right? So you would take good care of yourself by doing good exercise, eating properly, so on and so forth. Would it be nice if, if you go into a supermarket and some would actually tell you that you should be taking this type of the food back home? You have a phone, you tap on the kiosk, and then it just, suggests with a certain food that you should take, because that's what your genome tells you. Would it be nice if, you go to a pharmacist and the pharmacist asks you if you have any episode of the adverse drug reaction, and you said, I never had one, but I don't know if the one that you're about to give it to me will actually cause me that problem. So that Genomic can also help And you see that all those require the computational genomic enabling platform because everything has to go through that before providing the information vital to different businesses. So in the future, we believe that we will be able to offer this one because at least we have enough experience and enough capacity to be able to offer this to everyone. So I think that I will end the presentation. I will thank all these organizations, including colleagues that have been helping me. And Professor Vorasuk is a key person who, one of my teachers, who actually taught me everything. Just before the presentation, I asked him about the whole oxalate synthase deficiency. So that I learned from him too. So thank him for that.
Thank you, Ajahn Sissades, so much for the great presentations. And up next, Dr. Boonsri, Chanrachakul, head of the Maternal Fetal Medicine at Samitivej Sukhumvit Hospital, will present in the topic of preconception to newborn screening. Please give him an applause.
Okay, thank you, Vijay, for giving me a chance to have a talk here. So the topic I'm talking today is about the preconception to newborn, what we are doing, because actually I'm an obstetrician, so looking after the high-risk case, so we have to prepare the patient well even before they get pregnant. So why genetic involved with obstetrics? The genetic disorders and congenital anomalies about 2 to 5% of the live birth, and genetic disease responsible for about 20% of newborn mortalities and 10 to 30% of the pediatrics admit in the hospitals. And another thing is this genetic disease not only affect the baby, but it also transfer the disease to the next generation. And like Dr. Vorasuk said, now the cost of genetic test is very cheap and we can do it very quick. So this is our protocol. So what we do is start from, I don't know whether I can use the pointer here. Actually, we start from doing carrier screening because when the patient want to get pregnant, they come in, we do the carrier screening. If it's positive, then we have the option on the left-hand side, IVF, PGT, donors or adoption. If it's negative, we let them get pregnant. And after get pregnant, if we find something wrong, then we go on to do the CMA, whole exome, whole genome in the baby. If everything normal, we do the Down syndrome screening. And now we turn from the NIPT to the genome wow NIPT, with I will talk about the results today. And after the baby born, we do the newborn screening. So this is all the process that we are doing. So the carrier screening actually starts from 1970s, and what we do is we're looking for the people who are carry the disease with pathogenics or likely pathogenics, and identify this individual even they don't have any phenotype. In the past, we do the ethnic base, but the problem now is like we have cross cultures, people traveling, so most of the people are now like mixed ethnics, and even some people don't even aware that what are their ethnic. So it's difficult to do the test according to the ethnic. What we are doing now, we call the expand carrier screening, but now ACMG saying that it's better to call carrier screening because expand is not specific. Mainly we look at the autosomal recessive and the X-linked disease. And this is the new recommendation of the ACMG when they remove the expand word out. So they divide the screening into 4 tiers. In the past, the ACOG, the Obstetrics Society, used the second tier, any disease that more than 100. But after this recommendation coming out, now for pregnant women, we move from the second tier to the 3rd tier. So now for people who want to get pregnant, we do the 3rd tiers, which is the disease that more common, less common from more than 1 in 200 with the X-linked disease. So now we use the 3rd tier to screen for the preconception and the prenatals. So let's say that if the patient have carrier, what are the options? First, some people might don't want to do anything, we just get pregnant first. They don't mind 25%, 50%, and then they do the prenatal, and maybe they want to continue or they want the termination. Some people don't want to get pregnant straight away. They go for the IVF and do the PGT because we can get the cell from batosis and do the test before we putting in. Some people go to do the donor, maybe donor gamete, maybe donor embryos, and some people just give up and do the adoption instead. some people saying that better not get pregnant, just wait for the next life, start again. So what we are doing this year, the result that we are doing, we start to do carrier screening in 2017, and these results until the August this year, we have performed 222 individuals with 139 female and 93 males, and we have 78 couple who come and do the test at the same time. Before this, we have more people outside Southeast Asian, but after the COVID, people not coming. So most of the people who coming is Southeast Asian people. So this is our result, which is very interesting. We found that 72% of people who come in, 72% carry at least one disease. 40% have more than one disease. And if we use the old recommendation of ACOG, SMG, 84% is out of the recommendation. You can see that the people who have one disease is actually more than people who don't have disease. So that means the carrier is very common in Thai population. This is interesting. We found that 70% have carrier, but 9% have the same disease. This is the people we are looking for. 9% have the same disease. That means 25% of this couple can have baby with the disease. This is talking about autosomal recessive. But if we go to the X-link, if we take away the G6PD, there's one case of the Fragile X and one case of the DMD. So it put together 16 cases. That means 16 out of 145. That means 11%. 11% of the people who come for screening have chance to transmit the disease to the next generation. X-link 50% to the boy. Autosomal is 25% to everyone. Let's say if we don't talk about 50%, we talk about 25%, what happened? That means Thai population that come into our clinic, they have 2.75% to have the disease in their sibling. How big is 2.75? Everyone know about Down syndrome, right? Down syndrome is about 1 in 800. 1 in 800 is mean 0.1%. We do everything to stop Down syndrome, which is only 0.1%. But carrier screening, we can stop 2.75%. That means if we can expand carrier screening, we can stop the disease 27.5%, 27.5 times more than Down syndrome. That's why we think if it's affordable and more people do it, we will get like more healthy people in our population. So we look at the details, what we're getting. So far we get 99 genetic conditions in our population. Thalassemia 1 in 4, we know it's very common. GJB2 1 in 6, it's very common for Thai population, definite GJB2. SMA 1 in 55. And what interesting is that if we take away the common disease, the list below like 90 diseases, they are inborn error of metabolism. Most of them are inborn error of metabolism. That's why we start the project newborn screening in our hospital like a universal. Everyone who give birth in our hospital will be screened for inborn error of metabolism. Even it's rare, but collectively it's about 1 in 900. We don't know the number in Thailand, but I reviewed the study from Sirirat Hospital, but this study look at the high risk group. It's about 11%. We don't know how much. I don't know whether Dr. Vorasuk has number. I don't know how often in Thailand, but the thing is like the newborn screening is very effective. It's 99% sensitivity and effective, and it's very cheap. It's very cheap. So far, what we do, we start doing this last year in January until this year. At first, we screen only the TSS and PKU, but after that, we screen all the panel. Mainly we use the Sirirat panel, but some Japanese patients need to use their Japanese panel. So the result, we did the screen 1,461 newborn screening and 1,444 hearing tests. Luckily that none of them positive for any disease, but maybe because our population is low risk or something. But we keep on doing and we think we might get the number. And I think if the Songphol, I don't know what in English, can provides newborn screening free for everyone, I think it's better that we can detect more disease. They said 5 minutes more. Okay. So carrier screening is ideal to perform before pregnancy, and the information is private. So it's up to the patient whether they want to tell the family or not. Let's talk about prenatal screening. When baby born, what can happen is first, 3% can have structural anomaly, 1% can have chromosome, 1% can have submicroscopic, and 1% can have single gene disease. But part of the single gene disease was screened out from the carrier screening. NIPT was introduced in Thailand in June 2012, and I think now NIPT is quite cheap and have done in a lot of hospitals. But now what we do, we move from NIPT to the genome wow NIPT. Genome wow start in 2015. The benefit is that it not only look at the common trisomy, it can look at the sex aneuploidy and rare aneuploidy, and also the for overlap we can do micro deletion above 7 megabase. 7 megabase. Let's see our result. Normally the accuracy is about 68 to 83%, but if you see when we do the full screening, you can see that when you do genome wow, we can detect the disease 24% more. And what is in 24% is the rare aneuploidy 13%, is the complex CNV 4.5, and isolate CNV 7.2. That means if we don't do the genome wow, we will miss 24% of the diseases. So this is the result from other countries. Let's see our result. Another thing is that even the genome wow for the rare disease become positive. Most of them are the confined placental mosaicism, is not the baby. But is it important that what the effect of CPM to the baby? Actually, for CPM, even the baby is normal, but this baby will have complication. Let's say it's a CPM for trisomy 7, the baby will be very small. It needs to be close follow-up. If it's the CPM for trisomy 16, the baby can have preeclampsia, can have FGR. If the CPM from trisomy 20, the baby can have preeclampsia. So even the CPM doesn't cause structural defect, but this group of baby can have a pregnancy complication and need to be close follow-up. Our result, we have done genome wide NIPT since last year. So far we done 4,880 individuals. This is the result. If you look at the rare autosomal trisomy, we can detect 12 cases. And 2 of 12 cases is confirmed to rare autosomal trisomy. So the screening positive is about 0.25, PPV is about 8.33. Looking at the CNV, we look at CNV like bigger than 7 megabase. We can detect 10 cases, and 2 cases is confirmed true positive. So the screening is about 0.2 with PPV about 20%. We also did the single gene disorder. Single gene disorder is very unique because in the placenta they don't have CPM for the single gene. That means single gene can be the PGD, can be a diagnosis instead of screening. So far we done 44 cases with the monogenic gene. Luckily that none of them are positive. None of them are positive. Look at this case. I just want to show this case a little bit. I don't know how much time we left. 1 minute. Okay, just a short case. This is interesting. This is Thai pregnant woman, the first baby, 33 years old. She came to see me at 11 weeks, and we did the NIPT, the conventional NIPT. We look at chromosome 13, 18, 21. The result is low risk. The baby is a female. After that, she go overseas with the husband, happily, and she come back at 21 weeks. 21 weeks, we did the scan. What we found is a big VSD. And tricuspid regurgitation, and you can see the overriding aorta. So this is the heart defects. Heart defect. So when they got heart defect, what we do is we have to do amniocentesis at 21 week. So we do amniocentesis and we send for the CMA. The result is trisomy 22. It's not in the common trisomy. So we are interesting to see, like, in this case, let's say if we do the genome wall at the start, what happened? So we ask the company that we send the NIPT to run the sample that they already did, and NIPT come back trisomy 22. So we interesting to think that, let's say if this case we send the genome wall from the start, and we know that it actually trisomy 22, whether it will change the treatment. We might tell her that not go overseas with the husband, stay here, we do the CVS, we follow closely, and we don't have to keep baby till 21 week. We don't know. But after that, we stop doing conventional NIPT. We do all the genome wall NIPT. But luckily, our patient is affordable. So most of the patient now, we do the genome wall, and let's see the result ahead, that what we getting from the genome wall NIPT. So this is the protocol that we are doing now. So what we are doing now is that if people want to get pregnant, we do the carrier screening. If positive, we do the IVF PGT. If negative, they let them get pregnant. If they have miscarriage. Now, anyone who miscarried, we send for the CMA and karyotype. And we found that from our data, like more than 90% have CMA abnormal, but most of them are karyotype and aneuploidy, more than in the research that says 60%. And if it's normal, but the reason that we get aneuploidy from the miscarriage, because now most of the patients who get pregnant early, we give the progesterone because we want to take away 20% of the corpus luteum insufficiency. I think that the last one, yeah, okay. I think that may be the reason. Do I need to stand up? I can sit down. Wait, let's go. Okay, so now we know the genome wall instead of the common trisomy, and if they have something long, we do the CMA whole exome. And in case we have the FAU, the fetal death, now we do autopsy. And if anyone who don't want autopsy, we do the whole body MRI. At least we have something to see after the baby born. And then we do most of the cases that die, we do CMA whole exome and karyotype, because we found quite a few cases that CMA negative, karyotype negative, but whole exome give us the answers. And if the baby born, normally we do the newborn screening. So this is our protocol right now. I think it's time, right? Okay, thank you very much.
Thank you, Dr. Boonsri, so much for the great presentations.
Good afternoon, everyone. Thank you for BGI for the opportunity to present today. My topic is about colorectal cancer. Actually, it's kind of very large topic. So I try to make it like easy what we are doing now regarding the screening process, treatment, and surgery. Just touch a little bit, not in the deep details though. Okay, so usually, so we all know that colorectal cancer is the third most common cancer in all over the world. Actually, in the U.S., it's a second leading cause of cancer death in the country, and almost 60,000 patient deaths last year regarding with colorectal cancers, and most of them can be easily cured by found it earlier and treated earlier, and the incidence is increased not only in the elderly patients, and nowadays there's increase of trend in young onset patients too. So let's see now in the data say that 40 to 49 years old patient has an increased incidence of over time to 15% now. And most of the death can be avoided by early screening. So this is the trend of colorectal cancer this year. Most of the patients who got cancer in the elderly age, older age, the number is getting lower, as you can see in the blue line. Comparing to the young age patients, there's a lot of people got who is young and got cancer. So this is our Asian country trending. It's also the same as the US patients, because maybe in Asian country now we are westernized, like food and lifestyle is gonna be uptrending, especially in young onset patients less than 50 years old. So the risk factors, as we know, are alcohol, smoking, diets, obesities, physical activities, and also there's a non-modifiable risk like ethnic and hereditary colorectal cancer syndrome, something like that. So as we know that colorectal cancer is a adenoma and carcinoma sequence. Usually they have some kind of mutations, and then from normal epithelium gonna have change to adenoma, like polyps, and then polyps turn to be carcinoma later when they have like more mutations. So I will not go in deep into that things. So the clinical features are bowel habit change, rectal bleeding, blood in the stool, loss of appetite, abdominal discomfort, weight loss, bowel doesn't feel empty. You feel like you have to go to the toilet every time, many times a day. But mostly, colorectal cancer have asymptomatic. It means that you have no symptom at all. This is very important. In this picture is the tumor that we usually have in Thailand, in Asian country, huge tumor, and then we have to invest a lot to do surgery, chemotherapy, and everything for this kind of tumor. So if you have good screening policy, we're gonna find small tumor that curable, easy, don't need to have any adjuvant treatment, no chemotherapy, no radiations. So this is very important for our country, and especially in these particular regions, that we need to have a good screening programs to find a very early stage cancer, so that we can improve the outcome. So the colorectal screening, we all know that the age, if you have average risk, it means that you don't have any symptoms, you don't have family cancer, you don't have any cancer run in your families, you are average risk. If you got 55 years old, before that they recommend 50 years old, but as I said before, the trending of young onset patient is going up and up. So now the recommendation changed to 45 years old already. So if you got average risk, 45-year-old, you need to be to have screening. But if you have increased risk, you have to get a screening test before that, before 45. So as I said, now we change from 50 to 45. If you have the increased risk, you maybe need earlier checking. So what's kind of testing that we have nowadays? So we have stool-based tests, like FOBT that find the blood in the stool, and the FIT test, the immunohistochemistry test for the hemoglobin that in the stool, and we have the stool DNA. Next, we have blood-based tests. We try to find the methylations, the same way that stool DNA have try to find, but we try to find in the bloodstream. And the last one is the direct visualization test. We know that colonoscopy, CT colonoscopy, flexible sigmoidoscopy. So this is stool-based test, FOBT, which is finding blood, FIT test, hemoglobin, and also stool DNA. The DNA of the tumor, and including the polyps that go into the stool. I think now in Chulalongkorn University conduct a comparison study, which one is the best, and if the student is comparable to other kind of tests. So this is an ongoing trial. So this is blood test I already mentioned about. So in conclusion, is if you got 45 years old, no risk, you need some kind of testing. If any kind of testing you got positive, you need colonoscopy. Why do you need colonoscopy? Because you can see everything in the by your bare eyes, right? And if you see the polyps, you can remove it at the same time. So this is very benefit of the colonoscopy. So now I go to the treatment options. So nowadays we got surgeons is not like play a big role in the colon cancer treatment anymore. So nowadays we have like what we call multidisciplinary team approach, which includes surgeons like medical oncologists, radical oncologists, and in the labs peoples that we need to find the best way to treat that patient individually. I mean, precision, we call that precision medicine, that what kind of treatment that specific to each patient. So, and then I'm gonna talk about the surgery-wise though, because I'm surgeon, so nowadays we use like minimally invasive surgery. We put a very small instrument through that part that introduce the very small, tiny instrument to do in surgery, like this. Okay, so when the surgeon doing surgery, we're gonna put just a very small tube. Actually, it is an instrument that at the tip you can have like you can open, you can grasp it, you can cut it, you can cauterize, you can do anastomosis. So everything use a very small incisions. So this is example of surgery. So as you can see, we can do surgery, very delicate surgery. We can find a very small vessels, no bleeding at all. You can see there's no blood in the fields. We call bloodless surgery. So nowadays our surgery is very advanced. Don't have any bleeding. Okay. This is a very small vessels, and the nodes around the vessels we already retrieved by the principle of the cancer surgery. Okay, so this is the difference. So before that we got open surgery, very huge one. We got stoma, and then nowadays we have like very small incision surgery. That's the pictures after 2 months after surgery, after keyhole surgery. You cannot find any scar of the surgery at all. Okay. Next, nowadays we use robot to do a surgery to help us doing surgery. So this is the arm of the robot. So this arm of the robot basically the same as the laparoscopic surgery, but it's going through the port, the same things. But we control outside the patients. We sit down outside the patient beds and move the instrument by remote control. This is the example of robotic surgery. As you can see, the angle of the instrument is like your wrist. You can move your wrist like very same as you do your hands movement. So this is very advanced surgery. As you can see, you cannot see any blood, no bleeding at all, right? So, as I said before, colorectal cancer now there is not like surgeons role, the only surgeon's role. We have surgeons working together with the oncologists, radiologists, radiotherapists, and sometimes we need some other modalities too. So I would like to show you, because the topic is about how the genomic transform using that kind of technology to improve our treatment. So as we know, the colorectal cancer, some group of patients got DMMR, what we call that MSI. I would like not, I don't like to go in deep, but MSI is mean that you got some kind of mutations that you can, in that kind of patient, have a lot of immune response to the white cells and the immune response of that patient. So these particular patients who have this kind of mutations, there's a role of immunotherapy because it's going to respond well to the immunotherapy. Look at these pictures. Unresectable, we cannot treat these patients. This patient, before that, this patient is go to the palliative treatment. They're gonna die very soon. But after immunotherapy, the tumor is gone. We can, if you compare the left side and the right side, the tumor is much smaller after the immunotherapy. Like in this case too, this is a very young onset patient who got a big tumor close to the vital structures, cannot be resected, and then after immunotherapy, the tumor is gone. This is another example, huge tumor in the pelvis, and if you have to do surgery, it's going to be huge surgery. The patient can be very a lot of morbidities after the surgery. So after immunotherapy, the tumor is gone. This another example is a very young onset patient, 42 years old, and then he got a lot of liver metastasis, unresectable, and also the primary tumor is in the sigmoid colon. After immunotherapy, the tumor is gone. We cannot find any tumor, and the liver surgeon said that the patient don't need to do any surgery because they cannot find any tumor. And then we go in to do colon resections, and then the pathologies come out as pathology complete response to. There's no tumor left. So this is a new era of treatment of colorectal cancer nowadays. And then I would like to share our experience in using the multimodalities treatment in Chulalongkorn Hospital. This is only 30 years old poor lady who got mucus blood stool. At the time she got diagnosis, she just know that she got pregnant. Okay, and then she traveled around the country and said that all the doctors said that she need to take abortions to remove the baby out. So the patient come to see me, and then she cried a lot with her husband because she wants this baby alive. So you can see the tumor is there in the rectum, and you can see the head of the fetus is in the uterus already. So I make our MDT, which include the obstetricians and the pediatricians too, into our MDT, and then we try to find the best way to taking care of two patients right now, not just the mother and now her son too. So we have specific timeline of treatment, specific neoadjuvant chemoradiations, specific time of their fetal delivery, specific agents, and then specific surgery for this kind of patients. So after that, this is we deliver the baby and do surgery after she got specific treatment or neoadjuvant treatment. So nowadays she's an influencer in the TikTok, what she call, and then she got like 400,000 subscriber, and then she tried to encourage patients who got colorectal cancer to have like their life better, how to deal with that in terms of inside and outside too. So this is our proud. Okay, thank you.
Thank you, Ajahn Songphol, so much for the great presentations.
Good afternoon. Okay, first of all, I would like to thank you for the organizer and the sponsor for giving me an opportunity to give a talk in this wonderful event here, and then to share the thing that we did in Malaysia, actually dealing with the rare disease. And an application of NGS technology. In this case, we are doing on whole exomic sequencing technology to the rare disease. Oops. Can I go next? Okay. Just start that. Actually, I'm from bioinformatics program at the Institute of Biological Sciences in Faculty of Science in University of Malaya in Kuala Lumpur, and also at the same time also the head of a research center in bioinformatics called Crystal. Okay. So actually talking about primary immunodeficiency disease or PID, actually this is a rare disease with a minor allele frequency, or we call it as MAF, with less than 0.01. Actually, why we are using this, sorry, go faster. Why we are using this minor allele frequency? Because depend on the country. Some country define rare disease as 1 per 1,000. Some country call it 1 out of 10,000. So it's very difficult to make a fixed cutoff. Where is the rare disease? So because of that, we check on the database, and then based on that analysis, we came out with a conclusion that the minor allele frequency would be a good idea to define what is called rare disease. So for the PID, is a part where the body immune system is missing. So because of that, the patient are having a recurrent infection, allergy, it can have a malignancy, like tumor, autoimmunity, autoinflammatory, and then they have a lot of very severe condition. So, and regarding this PID, we have 515 conditions. So a lot of conditions that caused by 430 genes. And it's very difficult for clinicians to give a diagnostic based on the symptom. So because of that, they need some kind of way on how to give the proper diagnostic to the patient. So usually in diagnostic, as mentioned by our clinician before, that in order to give the diagnostic, we need based on the clinical symptom or sign, or by the patient family history, or by the physical examination, or by the laboratory diagnostic test that give us a very specific diagnosis for the patient. And we also have a molecular genetic diagnosis such as PCR, Sanger sequencing, to give the diagnosis. But for the case of PID, because if they have a symptom, it can be came up from various type of genes. So it's difficult to come up with a specific diagnosis for that patient. And to do Sanger for out of 430 genes is going to be a lot of cost and a lot of human labor. So it's difficult to do so. So meaning that this diagnosis is very difficult, especially when they have a lot of, sorry. Okay. Okay. So because they have common symptoms coming from different kind of diseases, and sometimes they have a very complex or atypical clinical phenotypes that makes it very difficult to diagnose. And then there are a lot of other challenges, such as they can be caused by different genes, And also, sequencing is very laborious and costly and time-consuming to do this type of analysis. Because of that, if we look at Malaysian scenario, the diagnosis of PID, PID, REI is the same thing, is delayed by about 3.87 years. So meaning that this delay can cause a lot of severity to the patient, like for example, organ damage, mortality. So we need to make a better diagnosis for the patient. So due to that, actually I'm a bioinformatician, not a clinician. So we talked to the clinician, they told us their problem and what can we do to help them. So we come up with the concept, why don't we try to run next generation sequencing with this patient and try it on this case. So what we run is whole exome sequencing, where we use this NGS technique that involve only on specific region, which the exomic regions. And then based on that, we can reduce the time compared to the using a lot of multiple Sanger sequencing. So using this whole exome sequencing, we can identify the variation, like for example, a single nucleotide variation. And then we can also identify if there are any insertion or deletion in the exomic region of the genome. Okay, so this is the workflow that we did. Usually the patients will come out to the clinics, and then we are going to do some screening. There are patients that we excluded from the study because of the complexity. Usually it comes with the abnormal BTK protein expression or abnormal neutrophil function. We exclude them from the studies. And then we include the one with the normal BTK expression and normal neutrophil oxidation or function assays. And then we do the three part, which is the clinician history, clinical history by the clinician. And then we do the laboratory test to identify what kind of symptom do the patient have. And then the next one, we conduct the whole exome sequencing, studying all the information regarding the sequence, the variants, and then based on that, we do the selection, what are the causative variant that causing the disease. And then at the end, we do validation using the Sanger sequencing to confirm that the diagnosis is correct. Okay, this is the cohort that we did. We did for 30 patients. We identified that there are some features, like for example, more than half of them are having pneumonia, coughing, and then most of them are having having bacterial infections or pathogen infections, and then they are also having abscess. So a lot of clinical features that making the patient ill. And then regarding the onset age, the median is around 4 years old, but some are very late onset of the symptom. Okay, so this is the West analysis, meaning that we identified that most of them are involved in the missense single nucleotide variation, around 67%. Some are having stop gain variation, some are having splice site mutation, and some are having frame shift deletion. So meaning that out of the patient, all of them are having some kind of genetic mutation that causing the disease. So this is looking at the inheritance patterns, whether they are coming from autosomal dominant, autosomal recessive, or X-linked type of inheritance. And then we also look at the zygosity variant from the patient out of these 14 successful cases. So actually, based on our West studies, we able to give the diagnosis of 14 out of the 30 cases. So meaning that's almost half of the cases are clarified using this West technology. So these are a few examples of them showing that they are with the type of gene, this is the mutation site, what kind of genes defect that they have for the disease. Okay, so I'm also going to talk about one of the case study that we published in our finding in the literature. A case from a non-consanguineous Malay girl that are reported with a lot of clinical summaries. They have sepsis, abscesses, they have fever, vomiting throughout the years. So the child is very sick. So the clinician cannot identify what is the reason for the sickness. So they pass the sample to us, and then we do West analysis in order to identify that. Okay, so the concept is to identify what are the genetic reason for this phenotype. So we did all the bioinformatics analysis from the West sample. And then this sum only for the West data analysis. We identify a lot of sequence from that. Okay, and then this is the variant analysis. From West data, we identify a lot of variants. Okay, okay, and it's coming from 9,000 genes. And then we screen one by one, try to screen out what are the causative genes. And at the end, we identify one particular mutation that causing the disease. Okay. Okay. So actually, the disease is caused by this gene NLRC4 at the mutation sites 1970 when A is changed into T, and that mutation is the one that causing the disease. And then we're able to identify that and then confirm it using the Sanger sequencing, where we identify what are the genes. And then the interesting part, we identify that the parents are normal, meaning that the child developed the mutation on her own, meaning that it's not inherited, passed by the parents. So this is a case we call de novo mutation, where the child developed their own mutation at that location. Okay, okay, and then we compare the sequence with the rest of species to see whether it is real important site or not. And then we identified that these sequences are very important. The rest of the species are conserving, having the same. So meaning that mutation at this site is very crucial that causing the disease. So it gives us more evidence to tell that this mutation site is very important, especially because this is a novel mutation, meaning nobody's reported it yet before. So that is the importance of that. So, and then we go further in the analysis, try to identify what kind of biological event happened to the patient. And actually we identified there is a proteins that mutated inside that because of the gene mutation that changed the function of the protein. Okay, and then because of that, the proteins that usually is not active become active in the patient. So that's why the patient are having this type of symptoms. And then we check also with, for example, the biological function analysis. We identified that there are a lot of cytokine expression for the patient. And then we look at the protein structure. We identify, oh, this type of mutation can cause this type of event. We did further analysis on the proteins. And then, for example, this is to look on the dynamics of the protein. How does the protein move? And based on that, we identified that the mutation is actually the one that causing this type of disease in the patient. So these are all bioinformatics analysis telling you that the result for the protein analysis that give us the conclusion that that is the mutation for the patient that causing this type of disease. Okay, so based on that, we're able to identify the real reason for the patient to be ill, and then we identified the proteins that involved in these cases, and it creates us new opportunity to design a drug that targeted to this gene that can be able to develop for the treatment of the patient. Okay. Okay, so this is, I think this is okay. Some reference. Actually, all these studies was published in 3 publications, and our publication, one of the publication for this one was awarded as a best publication by the British Community of Society of Immunology. So it was a very well accepted in Europe, which is a surprise for us because we just a very small lab doing something that was being appreciated by a big community in Europe. Okay, so this is our collaborator from Institute of Medical Research, which is a clinician on her own, to pass us the information of the patient. Okay, so I think that's all the presentation for me. Sorry, I'm a bit speed up because of the time limit. Okay, thank you very much.
Thank you so much for today and hope you enjoyed this event. Thank you.